All right, so welcome into night 2 of the 3-day EKG challenge. We are super excited that you are here because we're going to do some arrhythmias tonight. And arrhythmias are so important. And a lot of people have some kind of internal struggle surrounding arrhythmias. And I think this comes from the fact that um, once you understand that it's all about pattern recognition, it becomes a lot easier. If you also understand that the heart is just literally trying to tell us what's wrong with it, it's just using its communication skills. And the electricity is what we're measuring, right? So it's basically, we're always wondering, the question that we want to ask ourselves is who's running the heart? Okay. So in a normal heart, we want to see the sinus node, which is up on the top here, right? We want to see the sinus node sending the impulse down to the AV node where it slows down, and then going down the bundles and going down at the same time, provided there's no bundle branch block. And that helps contract the ventricles so you get the maximum amount of blood pumping out to the body. So that's what happens in the normal heart. But basically, we're asking the question, hey, who's in there? Who's running the heart? By the electricity and the tracings they make on the paper. So that's just a concept check. And then we always want sinus node to be in charge. The sinus node makes a P wave. We're going to be hunting a lot for those tonight. And of course, once the impulse goes down through the AV node, it slows down a little bit. We're going to be keeping our eye on that as well as the size of the QRS complex, the width of it. That's also really important because the wider it gets, the more likely it is coming from the ventricles. And yes, if this was my heart, I would absolutely have cardiomyopathy, no doubt at all. Okay, so hey, there you are. We have Lee on FB. Did I freeze? I think I might have frozen. Did I freeze? Yeah, I think I froze. Okay. If anybody could see on Facebook if I'm frozen, not on Zoom. Okay, cool. All right, well, we'll keep going. So let's get into the arrhythmias here and get down to it. But before we do, I want to announce the winner of last night's EKG kit. So if you remember, I showed you this beautiful kit with all the toys and the painting and the workbooks inside of it. And we actually have a winner. I hope that she's on tonight, Megan Wilbur. So Megan, you need to give me your address so that I can mail out your kit to you. And you can enjoy all the things inside of it, which are so fun. So make sure, Megan, if you're seeing this, and congratulations, get me your address so I can put it in the mail. Okay, now let's get on to the night's teaching. So if you recall, yesterday we did the workbook page. We did workbook page number 1 for day 1, and we also still have more workbook pages to do. So does anybody still need their workbook? Because if you do, let us know. We can get you the link. And I'm going to make sure we're in the right place again. Okay, awesome. So these are the answers, and these all live in the very top of the group under the guide session. So if you're wondering, oh my gosh, I didn't hear Jen say that one answer, you can go up to the printed ones that are in the guide section. So like for this example, you'd look in day 1 and you'd look under day 1 answers. So that's here. Just wanted to make sure you had access to that. And then we're going to get into how to solve these arrhythmias. So when you think about who's running the heart, the first thing you're asking, is it narrow or wide? If it's narrow, it's most likely coming from the top of the heart. If it's wide, it's most likely coming from the bottom, and it's ventricular. The next question you're going to ask yourself, and this is to keep you safe, is it fast or slow? If it's really fast or really slow, do we need to do any intervention right now? For example, if you have a really slow rhythm, maybe they need CPR, or they're, just super bradycardic, they still have a pulse. If they're really fast, like an SVT, maybe they need vagal, maybe they need adenosine. But do you need to do anything right now? If not, okay, we have time to keep moving. Now, the last question you're going to ask yourself in addition to, is there P waves? Because that's just a given. You're always asking if there's a P wave. Is it regular or irregular? And you're using the R to R intervals to do so. So if you come over here, this is the R to R right here, nice and regular, okay? This is obviously not a EKG that's it's meant for decoration, but I wanted to draw on it anyway. And while we're here, this is our P, right? We're always looking for the P. And this is our QRS, not too wide, which is good, okay? And we should have on every complex, right? We should have a P. So let me grab my heart tool. You should have a P, a QRS, and a T, and they should all be following the rules we talked about last night. So we talked more about that the P, right? It shouldn't be too tall or too small. The QRS shouldn't be too tall or too small. The P shouldn't be too close to the QRS. And if it is, it means WPW is likely. And the T wave shouldn't be running away from his dad, prolonged QT, and he shouldn't be too tall, ischemia or hyperkalemia, and he shouldn't be too small, hypokalemia is usually the cause of that. So there's a lot of information, even on this just decoration picture EKG, to look at, right? And as KJ said, sinus makes P. Exactly. Hi, Matt. Nice of you to join us. It's always good to see you again. All right, so let's get into solving some of these arrhythmias. We'll start at the top in the atrium, where most of the things that we're going to talk about are going to be from the atrium, because there's a lot of things. So atrial flutter can come in the atrium. Hi, Marie, how are you? You can have AFib or AFib with rapid ventricular response. So does anybody know, this is just a quick question, how do we define AFib with RVR? The heart rate is over what if it's AFib with RVR? The heart rate is over what number? It has to be over a certain number, and it's 100, exactly, over 100, okay? Now, you can also have SVT, which is always going to be fast. You can have sinus tachycardia. Yeah, it's a little mixed, right? But in a general consensus, if it's over 100, we're starting to do something about it. And then Wolf Parkinson's White can also come from the top, and PACs can come from the top. Oh no, Marie. Marie was our scholarship winner last time of our 30-day EKG challenge, and now she's in our 30-day with us, and she's getting in on the mix, saying hi to Matt and KJ, which is perfect. Now, let's talk about, yes, split the difference, exactly. Let's talk about what this rhythm is here. This rhythm here does not have a regular R to R. Okay, so it is irregularly irregular, and there is no discrete P waves, albeit some people would say, well, that looks like a P, that looks like a P. But the fact that it's irregular, and really that might look like a P to people, but it's too disorganized, it's too chaotic, it's too irregular. And whenever you're squinting to see a P wave, it's usually not a P wave, okay? So let's keep moving. That was AFib. And AFib, we got to ask some questions. We got to ask, how fast is it? And then we got to ask, what are we going to do about it? Are they potentially at risk for stroke? So in the meantime, let's talk about what normal looks like. So what is this rhythm called? Does anybody want to take a stab? Okay, let's see if we have any chats. Okay, yeah, this is a sinus rhythm. So we'd have to actually march it out to see what the actual rate is, but we know it's sinus because we have a what wave? We have a what wave? Yes, P wave, exactly. Good job, you guys. Chelsea, yes, you're here. I know you meant to say P. They're so close together. So we have a P wave, we have a regular R to R, and we have a P for every QRS, and then we have a T, and that's what we like to see. So it's a rate between 60 and 100, which is also good. And yeah, this is normal sinus. So you're always hunting for this. But then you can have other things that can be confusing. Okay? So you've got this rhythm, and of course, we're looking for the P. We're looking for that P. And you can see the P wave here, here, and here. Okay, so every QRS has a P. That's the big thing. But then the question becomes, what about that R to R interval? Because when you look at it, that's shorter than that. So this can make you think sometimes that this is potentially AFib, okay? And the question is answered because you have a P wave. This is not AFib. And yes, it is caused by breathing, and it is unfortunately a lot of times thought to be AFib. But this is sinus arrhythmia, okay? So sinus arrhythmia, let's talk about that real quick. Sinus arrhythmia happens in young people. It happens when they are breathing, and it's caused by good vagal tone. The treatment is none. We basically just observe, and the treatment is not putting them on a blood thinner for AFib. This is not AFib. Okay, so that's kind of the treatment there. Okay, so good job, everybody. You guys did amazing as usual. Now, sinus bradycardia is something you're going to see a lot. Okay, so this one is going to be a rate of like, well, you'd count out probably in the 40s, maybe high 30s. You could always count it out, but there's some things that tell us it is still sinus. We have a P wave, right? And we have, hold on real quick. Okay, sorry. So we have a P wave. It is slow and it is a regular rhythm. And things we can do to cause this, medications, right? Medications can cause this. Can you guys name any medications? Can you guys name any medications that could cause this? Let's see what you guys have to say. Zofran can cause prolonged QT, but beta blockers for sure. Labetalol. Gosh, you guys are fast. Hi, Marcia. Marcia's back. Yeah, so we can cause with medications. Good. And what's the fix? Get them off the medication. So if this is not reversible, if it's not reversible, then we need a, let's see if anybody got it. Pacemaker. Yes, good. Okay, you guys are all over it. Okay, so when I say reversible, what I mean by that is, here's the thing. Here's the thing to think about. Is their thyroid off? Is it med-induced, right? That's the other thing. Is it med-induced? And potentially we're looking at getting, a CMP, right? A CBC CMP, looking at their renal function, because increased K can cause it, right? So we want to think about all these things, and also ischemia can cause it. So if we rule out all of these things, then we can start thinking about putting in a device in somebody if they have profound bradycardia. And the key is they have to be, this is the key, symptomatic. Okay, if they're not, right, no syncope, no dizziness, no lightheadedness, then that's obviously someone we may be able to leave alone, because the big question we would ask them is, are you athletic? Are you athletic? Okay, so let's keep going. Now, this rhythm is one that is still sinus. I know Maria's on fire. This is still sinus, but it's fast, right? So it could be Chelsea flutter. It looks fluttery to me. I don't know if that's a word, fluttery. But at the end of the day, we would need to do a 12 lead, right? And this actually turned out just to be sinus tach, but they can look identical. So doing the EKG, the 12 lead is going to be the key. And then thinking about some common causes of sinus tack, because the treatment for sinus tack is actually fixing the problem. Okay, so some common causes, and you guys can type some in the chat. Okay, so common causes would be like anemia, pain, fever. I'm loving these. Anxiety, good. Dehydration, pain. I think we already got that one. Drugs like meth can cause it, right? Hypovolemia, that's another good one. Or what about sepsis? Sepsis. So all these things can cause it. So we treat the things, we don't treat the rhythm. Okay? Matt said that. Oh my gosh. Of course he did. Of course he did. Phentermine. Oh my gosh. Okay, so you stirred up a whole bee's nest on the phentermine thing. I was going to tell you. It is meth, my kind of girl. I know meth is very prevalent, but phentermine, it's interesting because one of my longtime 30-day EKG members was asking me, like, wait a minute, why are you talking about phentermine? Are they still prescribing that? And I think some people are still prescribing it, but it does cause sinus tack and it can also cause heart failure. So that's why they're kind of transitioning away from it and going to the more of like the Mounjaro, Ozempic type or Rybelsus type of situation instead. Okay. Yeah, you see it too much. I know. Same, same. Okay. So let's talk about this one. I know you guys are going to get this one because are these P waves? Oh, the weight loss clinics still provide phentermine? I do the same thing. I tell them they're not getting cleared. Same. I'm like, no. And one person was like, well, I'm just going to go to Mexico and get it. And I was like, okay, but it's going to hurt your heart. So if it's worth it to you, then when you come back, we can, fit you for a life vest, right? Good. Yeah. Like you said, same thing. I live near the border. Yeah, same. But we always just recommend against it because of heart failure. It's just, not a good drug. Not good. It does help lose weight, but it's not a good drug. So in the meantime, it is flutter. We knew that because of these non-P waves, these ended up being um, flutter waves, right? So flutter waves here, 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 here. So these are not P waves, okay? And they do have, you will look skinny in your casket, yes. They do have a risk, flutter patients, of having stroke. So we need to consider that. We need to do a CHADS VASC 2 score on them. And also flutter is honestly like better served by ablating it than just trying to medicate it because flutter is like super stubborn. Okay, so let's go to the next one since you guys already nailed that. And let's see if we can remember what this one is. Let's see if we can remember. It's irregularly irregular. That's the clue. Good, AFib. Okay, is it rate controlled? Is it rate controlled? Okay, so the answer is it too fast? Yes, it is rate control. It potentially might even be going too slow. And sometimes with AFib, you'll see like some pauses sometimes, especially if they're converting from sinus to AFib and going in and out of it. You'll have conversion pauses sometimes that are not something we would put a pacemaker in. We would just kind of keep an eye. Okay, but patients, what will they complain of when they have AFib? This can be lots of different things, right? So they can complain of fatigue. And you can type in the chat what you've heard. I've heard butterflies in the chest. Yes, KJ's heard that too. I've heard bubbles in my chest. What else have you guys heard? I feel lightheaded. I have palpitations, skipping a beat, dizzy. Yep, these are all good. Okay, excellent job, you guys. So basically have a low threshold to get an EKG when you see this, okay? Low threshold to get an EKG when you hear those things or you feel an irregular pulse. All right, let's talk about the junction. So what is missing here? There's something like very, yes, the P wave. I know I like typing on the slides too. It's so fun. Hi, Sinite. You guys all should hop on Zoom with us. That's where all the fun's happening. Hop on Zoom. Um, so there is missing a P wave. So who's in charge of the heart? Who is in charge? That's true, KJ. Who's in charge? Yes, the AV node. So again, you've got the missing P, which should be right there. And it's a little slower, right? Because the sinus node runs the heart about 60 to 100 beats per minute. It's nice and regular. The QRS is still skinny enough. And when you see this, you always want to think about ischemia to the RCA. Why is the junction running the heart? It's slower and it's outbeat by the sinus node all the time, right? And so at the end of the day, you really, really, really want to watch this closely. Think about ischemia. Think about are they on anything that could be killing their sinus node, basically, and get them off of it if you find something like that. All right, let's do the ventricle things, the ventricular things. Okay, now, what do you notice about the QRS complex? What do you notice about the QRS complex that is abnormal? It is wide, exactly. More than 0.12 or 120 or 3 small boxes, right? It's still regular, actually. And this is called an idioventricular rhythm. Okay, idioventricular. And the thing with this is patients can have a pulse or not have a pulse, right? And the key is just for you to make sure that they have a pulse. And if they don't, then you start CPR and all the other ACLS measures. But the key with this is you're probably heading towards something worse, and the something worse is usually something like this, okay? So this is called an agonal rhythm. It's bizarre, it's slow, and it's a poor, tired heart. Exactly. It's one little lonely heart cell down here trying to run the heart, and they're not going to have a pulse with this. And it's like basically kind of the end of the line. And then eventually you'll see asystole. But there are some rhythms that we need to know that are called sight rhythms, meaning you see them and you know them. Okay. So when you see it, you know it. I want you guys to type in the chat. Let's see who our fast typers are. What rhythm is this? What rhythm is this? Yes. VTAC. You have the fastest fingers ever, KJ. You're the one to beat, right? So it's VTAC, but how do you know that? Can you guys tell me why it's VTAC? You're right. And some people will go as far to say it's a wide complex tachycardia. It's a wide complex tachycardia, right? Because it's a wide QRS. It could be something else, right? It could be SVT with aberrancy potentially, but it's more likely that it's actually ventricular tachycardia. If you have fast, wide, and regular, it's an 85% chance that it is actually 85% chance that it is going to be at least 85 that it's going to be VTAC. Okay, so let's go back to here. What's this rhythm? Type in the chat what this rhythm is. Yes, exactly. This is ventricular fibrillation. It is a hot mess, right? There's no organization here. So this is obviously VFib and it's total anarchy. It's coarse VFib, exactly. When it's a little bit less voltage hanging around, that's more of a fine VFib. And this is a coarse VFib. So this is something that we need to, what's the treatment? What's the treatment for this? Defibrillation. Exactly. Oh my gosh. Yes. KJ, shock, 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 defib. Exactly. Good. Okay. Now, there's also extra beats that can come. And extra beats, we have a couple different flavors. These are called PVCs, right? We know that because they're wide. Their P stands for premature. ventricular contractions, okay? So they are wide and they are different morphologies. We haven't really talked about that term, but morphology means shape. When you have more than one shape of PVC, that's alarming because that means more parts of the heart are experiencing is most likely ischemia. So we get really, really worried about multifocal PVCs coming from more than one foci. Okay, so we're going to make sure we go through the workbook with you that pertains to tonight. So hopefully you guys have it printed out and ready to go. So we did this already. And then we did this yesterday as well. So you have all the answers, right? So you can hopefully read my chicken scratch. There was one person once that said they couldn't read my chicken scratch. And I was like, I'm so sorry. So Michelle actually, I think, retyped it for somebody because she's just so amazing. Okay, and this is day 2. This was for you to reference if you wanted to. You could make sure on your paper that you have an example of AFib in front of you, that you had the example of sinus arrhythmia in front of you, that you had an idioventricular one, and also junctional. Yes, I do write like a doc. This is actually really good writing for me, KJ. Yeah, it's gotten much worse as I get busier. But anyway, that's fun to do. And then let's do, well, we did these already. We did the VTAC, but what's this? What will we call this? Your penmanship is horrible. Me too. This is called a run a VTAC. Good, KJ. Okay, we would do that because it's fast, regular, wide. And what is this one? 3 or more, exactly, KJ. What is this one called? This is called, are you sure the patient's on the monitor? I like the skull and crossbones. The sad face, yes. This is called asystole. You guys are cracking me up. This is VFib. We talked about that already. Okay, let's do a couple of these strips. Let's just do some practice time. What's this called here? You can see fast and regular, and then back to normal. Oh, now we're normal. Okay, it could be sinus tach, but it's pretty fast. Yeah, it's too fast, right? And this is indeed an SVT converting into a sinus. So yes, Marcia, this is a PSVT standing for paroxysmal SVT, and it went away. So good. SVT is transitioning to sinus. This one, yeah, I know. Yay, Marie, right? This one is maybe a trick question. What do you guys think about this one? Oh, you got it. You can't fool Marcia. If Marcia's around, we cannot pull the wool over her eyes at all. Yeah, it's a little bit fast, right? And you could use a rule of 300 if you wanted to calculate the rate. Where the big line lands here, the next line would be a certain number, a certain number, certain number. But yeah, this is definitely so fast. And we can go over the rule of 300 if you guys want. But definitely sinus tach. This one is, I want to ask your opinion. I'm going to show you the rhythm strip. Let me move this. I'm going to show you the rhythm strip, and then I want to hear your opinion. This is our rhythm strip. Here or here. Okay? So, first things first, is this okay? Yes, I agree. There's some inverted T's. Agree. Okay, but is this sinus? It is sinus. Good. Always go to lead 2 if you're wondering. Okay? Always go to lead 2. Actually, I'm sorry, this is wrong. This is not a rhythm strip. It's only V1. I'm sorry, I did that wrong. This is your rhythm strip, but I would not use this because you can't see very well the P waves. I would go here and look at these P waves and I'd be like, yep, confirming I do have P waves. I have a regular R to R. Yes, this is sinus, but I've got a rate of 47. So this would be, yes, Chelsea, a sinus Brady. Good job. And also the QRS is a little bit wide, right? It's starting to get a little closer to 120, which I'm not liking. Because at 120, we start to worry about the bundles. We talked about that, but this is a sinus Brady. So let's talk about this for a second, okay? Because I just I want to talk about it. So let me go over here. Now, this was an actual case. This was a 36-year-old male, and his mom is a nurse that no pressure to get it right. And Apple Watch reported bradycardia. This is the EKG today. What's the first question you want to ask the patient? What is the first question you want to ask the patient? Okay. Does he do drugs? Okay. What meds do you take? That's very good. Okay. How do you feel? He says, I feel great. Are you an athlete? Winner, winner, chicken dinner, Chelsea, Marcia. Yes. Okay. He goes to the gym twice a day. Twice a day. Once before work and once after work. So, is it possible that who has time for that? I know, right? Like maybe he has someone who's the grocery shopping and the cooking for him. I don't know. But anyway, so that that would be great to go to the gym even once a day. So Apple Watch recorded bradycardia. So he feels fine. And everything, all the tests were fine. So that was good. But, um, yes, probably. So there was this inverted T wave here. And honestly, the T waves up here looked pretty big to me and actually all over the place. So I did want some labs. So the labs I want, yeah, they do appear to be hyperacute, which is too big. Okay. So the lab I wanted most was this. I wanted a K because I really need to know what the potassium is. The next thing that I really wanted was the stress test, but it was normal. And I wanted an echo because I had an inverted T wave. Echo was normal. And at the end of the day, these T waves, I could never explain them, but he was fine. So always be suspicious until proven otherwise. And always be worried about a heart rate of 47 unless they have no symptoms. They're not on any rate limiting agents and they're athletic, which is the case of him. So it's fun to kind of put this into practice. So sinus Brady, you guys got it. So, oh my gosh, we're to the end of the night already. And I don't want the fun to end, but we're going to give away a couple of these tonight. Okay. So these are made by our friend Matt Holden from Scope Education. And he has these badges that are so cool. These are the STEMI equivalent badges. We're going to be giving away 2 of these tonight to our people who are live. Yay! Okay, so if you would like to be in it to win it, in the Zoom here, why don't you put badge, and we will draw the winner tomorrow for the badge. And just a side note, we are going to be live tomorrow again at a different time. Okay, gotcha. Welcome, Cindy. I think everybody's yes, everybody was on fire tonight. Okay, so we're gonna be live tomorrow at 5:30 PST tomorrow, and tomorrow is our last night. We're also going to be giving away the scholarship to the 30-day EKG challenge. So tomorrow night is the most important night to be live. So again, it's going to be 5:30 PST. Come on Zoom because obviously Facebook is glitching right now with Zoom. So let's just do Zoom tomorrow. Let's just plan on it. It's a date. And yeah, I know last night, I know. But then we're going to start our 30-day EKG challenge next week. And if you guys want to continue the party, you can always join us there. So Chelsea's like, fingers crossed. You guys are amazing. So thanks for being here tonight, guys. We'll announce the winners tomorrow of the badges. You definitely want to win them. They're very cool. And I think that's it. Does anybody have any questions that we can answer for you? We will put the replay in the guides section. We'll upload a good recording and we'll see you guys tomorrow. Thanks so much for being here. Bye, guys.